active drug? If it is compared to an active drug, did they give the active drug in the optimal way? Or in some way, did they give it in a suboptimal way that was setting it up to fail against the new drug? We have talked already a lot about surrogates, so I think I'm going to, we'll go through this quite quickly. But higher, worth perhaps reinforcing the central point. Higher HDL is associated with lower cardiovascular risk. Who strongly agrees? Good. Raising HDL should therefore decrease cardiovascular risk. Who strongly agrees? Who agrees? Who disagrees? Okay, right, okay, you've learned the message, okay, good, you've got it, okay? So just because it's associated does not mean that a treatment that changes the surrogate will necessarily change the patient-important outcome. Okay? And so niacin in patients with low HDL cholesterol, we find that levels of high density, okay, no, that's the other one. Okay, basically, the bottom line here is it raises HDL, but it doesn't do anything for your cardiovascular risk. Okay? Yes? Should, right? Higher HDL, lower cardiovascular risk? No, didn't work. Torcetrapib. Levels of HDL are inversely related to cardiovascular risk. That's what we just decided. This was a drug that raised HDL. Okay? Total of 1,000 patients. In the first trial, 24 months after the trial, they increased the HDL nicely. Look, 61% increase in HDL. And it decreased LDL on top of it. Unfortunately, in another surrogate, but a down-the-road surrogate, the atheroma volume increased by 0.9 in atorvastatin and by 0.12 in the torcetrapib. In other words, no difference between the two. But that didn't stop them. They then did a trial of torcetrapib. Randomized double-blind trial, now 15 given the torcetrapib. At 12 months, there was an increase of 72% in HDL. And you got a decrease of 25% in low-density lipoprotein, a 1 in 10,000 p-value for both comparisons. Unfortunately, there was an increase in the risk of cardiovascular events, a 25% increase, a p-value of 1 in 1,000, and death from any cause, 6 in 1,000. Raising HDL beautifully, lowering LDL, and it kills you. Okay? So the logic, once again, the logic of HDL is associated with lower HDL, good events. We're going to raise HDL, we're going to prevent the bad events. Doesn't work. We suggested proteinuria. More proteinuria associated with lower cardiovascular risk. Who strongly agree? You guys don't know about this. It is, okay? The more you have proteinuria, if you follow patients over time, those with more proteinuria have more deterioration in their renal function. Yes? Okay? Makes sense? Okay. So, let's see, what am I doing time? Okay, I'm just going to, the bottom line of this one is you had treatments, the treatment that, they were looking at telmisartan versus ranitidine or both. Although a combination of therapy reduces proteinuria to a greater extent, it worsens major renal outcomes. Same story. Proteinuria associated with bad outcomes. You give less proteinuria, you get more bad outcomes, going in the opposite direction from the way you would expect from the surrogate, its association with the patient-important outcome. Okay. Bottom line is, I could go on with these stories about, there's endless stories of surrogates not working out the way they should. The association between the surrogate and the outcome does not mean that changing the surrogate is going to change the outcome in the way you want it to do. So, and here's where the good is over there. So beware surrogate endpoints. We think we should be highly skeptical about surrogate endpoints. Outcome of elderly patients with chronic symptomatic coronary artery disease, okay? Primary outcome, a composite of death, myocardial infarction, and admission for ACS, okay? So we're giving a invasive versus optimized medical treatment, combined outcome of death, MI, and ACS admission. Here's the composite, a 69% relative risk reduction, upper boundary of the confidence interval. It's at least a 55% relative risk reduction in the composite of death, MI, and ACS admission. Sounds wonderful. And look, ACS admission, it reduces it by over 80%. Unfortunately, MI, maybe it reduces, but it might increase it by 55%, and death is going in the wrong direction. So, what do you think of the composite of death, MI, and admission for ACS?
They're using ACS to dilute out death.
Okay, what has gone wrong? Widely varying importance. Death and MI are important, admission for ACS considerably less so. The biggest effect is on the least important, and on the most important, no effect. If you want to believe the composite and not look at the components, there needs to be similar patient importance and a similar effect. Study illustrating this, they looked at blood glucose control and vascular outcomes in type 2 diabetes. Randomized trial of 11,000 people, diabetics or standard, and they managed to lower the blood glucose. Intensive control, they got their A1C down from 7.5 to 6.5. The standard went down a little bit, but then back up again. So you almost always a 6.5 to 7.5, lower blood glucose. Composite outcome, major macrovascular and microvascular events. The macrovascular events were stroke, MI, CV, death. Microvascular events, renal replacement therapy, development of albuminuria. Overall, 20% of these composite to 18.1%, excluding no effect. Positive trial. Major macrovascular events, MI, non-fatal stroke, death from cardiovascular causes, confidence intervals, these two, no effect. Looks like a trend here, but everything overlaps, no effect. Microvascular events, new or worsening nephropathy, action. New or worsening retinopathy, no action. Here, there seems to be some action. So, new or worsening nephropathy. Just a second here. What a pity. So I'm going to have to tell you what should have come in here in the next slide. This new or worsening nephropathy was all driven by albuminuria. There was, in terms of need for renal replacement therapy, nothing. So this whole composite up here is driven by the new or worsening nephropathy, which is all driven by albuminuria. So, severe hypoglycemia, 86% increase in hazard, 1.2% absolute increase, hospitalizations up by close to 2%, again probably driven by increased admissions because of hypoglycemia. The author's conclusion, a strategy of intensive glucose control that lowered the glycated hemoglobin to 6.5 yielded a 10% relative risk reduction in the combined outcome of major macro and microvascular events, primarily as a consequence of 21% relative risk reduction in nephropathy. This, if you read the conclusion in the New England Journal, if you just went to the abstract and read the conclusion, that's what you would read. Alternative. 5 years of an intensive glucose control involving increased medication result in an absolute decrease in albuminuria of 1.2% and an absolute increase in hypoglycemia of 1.2%. composite endpoint. So fourth message, beware composite endpoints. They are often driven by the least important of the composites, and nothing's happening in the more important. And so if you accept the composite, you will see a bigger, it will be in effect much more important. It will seem much more important than it is. And in this last extreme example, it's driven by a surrogate. So this was a real catastrophe when this combined thing of major macrovascular events looks wonderful. It's actually driven by very much the least important outcome, a surrogate. So somebody throws you a composite endpoint, which happens in about 50% of the cardiovascular trials. You need to be skeptical and look at the components. Final story. 5 versus 4 courses of therapy for acute myeloid leukemia. Acute myeloid leukemia, nasty, kills you, but the chemotherapy is no fun either. You wouldn't want to give a 5th course of the chemotherapy unless it really did something. So here's the trial. First look at the data. 7 in 100 patients who had 5 courses, 7 deaths, 4 courses, 15. 57% odds reduction in death, p-value 0.05, which means it just touches no effect. Okay? So, who thinks that the investigator should have stopped here and said, well, look, this new treatment is preventing death. We should stop the trial and give everybody 5 courses. Who thinks they should have stopped at this point? Nobody thinks they should have stopped. They didn't. They went on. Their next look, we now have 23 out of 171 and 5 die, 42 out of 169, 53% odds reduction, lower boundary of the confidence interval, a long way from no effect, a p-value of 3 in 1,000. Who thinks they should have stopped then? Who thinks the options are stop now and give people the 5 courses, or keep the trial going and half the people still get 4 courses?
They should stop.
Who thinks they should stop? Who thinks they should keep going? Okay, good. You guys are so smart. Here's what happened. They kept going. Had they stopped, when at least some of the people here would have had them stop, we'd be giving out the 5 courses of chemotherapy with no benefit. So, why does this happen? Consider a therapy with a true small effect. And we're going to do a bunch of trials. So, thank you. So, some of the trials might start with an effect near the truth, but a lot of them, and stay that way. But some of them will, early on, because of the play of chance, show harm when the truth is a benefit. But as patients accumulate and random error goes down, it'll move toward the truth. And some of them will start with big overestimates of the effect and then move toward the truth. What if we look at the data after every patient and say, we set a stopping boundary to say, if it looks like a big effect, we're going to stop. And you look after every patient. Any of the trials that are done that ever cross this, you'd stop and declare victory, and you'd get a big overestimate of treatment effect. Statisticians have recognized that for a long time, that said, no, we shouldn't look after every patient. Let's just look periodically, after 250, after 500, after 750. That reduces the problem, but it doesn't stop the problem. If any of those looks happen when you cross that line, you stop, declare victory, and you overestimate the treatment effects. And all the modeling studies that have been done, anytime you start looking on the basis of the data, sometimes you're going to overestimate the treatment effects. And when there's small number of patients and events and you look, you're going to have big overestimates of the treatment effect. So, number 5, beware trials that stop early for benefit. They are going to systematically overestimate treatment effects, and when they do it on relatively small numbers, they're liable to be very large overestimates of the treatment effects. So, 5 strategies for avoiding being misled. Read the methods and results, bypass the discussion, which when it's a pharmaceutically funded study, or even if it's not, people like to, have positive results. The discussion's not gonna help you. So the method, or it's gonna mislead you. Look at the methods and results, but we don't have time to read the methods and results. So you need to find a trustworthy source that's going to interpret the evidence for you and present and give you an evidence summary that you can trust. Beware faulty comparators. If a new drug is compared to placebo, think should it be compared to an active drug. If it has been compared to an active drug, make sure that active that it's been compared to has been administered optimally. Number 3, beware surrogate endpoints. We would suggest don't give out the treatment until it's been shown to affect something that patients consider important. Number 4, beware composite endpoints. People will say admission for ACS, MI, and cardiovascular death when it will all be driven by admission for ACS. In the extreme, they will put something together with macro and microvascular events, and it'll all be driven by albuminuria. You have to look carefully whenever you see a composite, what happened to the components. And finally, trials stopped early for benefit will systematically overestimate treatment effects. When the number of patients and events are small, you're liable to get very large overestimates of treatment effects. Okay, so that was a relatively rapid-paced discussion of these issues. Any questions or comments? Yes?
So how do you know when to stop or when you've reached true effect?
We believe that we argue for never stopping early for benefit. We are in a minority doing that, but what we'd say, if you are going to stop, look only once and look as late as possible. So we encourage people to only, in our own trials where we do stop, we will look only once and we'll look after 2/3 of the patients have been enrolled, where the risk of a false positive, of overestimating treatment effects is less. Yes?
At least conceptually, you put a graph up there that showed that it might show early harm, but later on show significant
Yeah.
benefit. So how do you navigate the not stopping for harm side of things?
Much more difficult. So we are convinced that you shouldn't stop early for benefit. We're ready to argue strongly for that. Much more tricky with harm, okay? If you stop early for harm, you overestimate the harmful effects the same way, no question. And if it's a small number of events, there may not be any harm at all. But it's much trickier, because if you don't stop, and it turns out that there is serious harm, and the family members of the patients who died because you continued came and said, look, you saw a signal of harm early and you kept going. That's hard to defend. So I'm afraid that perhaps we have to give up some treatments that might have ended up not being harmful and beneficial, because it's really tough, even though you know you're overestimating the harm, not to stop when you see a really compelling, an apparently compelling harm signal.
How,
And so we haven't written about that because we don't know what to do.
how much harm was there in the early beta blockers for heart failure trials that got it established as a new paradigm?
There were no trials. It wasn't done on the basis of trials. All that bit about don't give beta blockers for heart failure was because of physiologic reasoning. Right? People said beta blockers, when you give beta blockers, your cardiac output goes down. Therefore, why would you ever give it to heart failure? It wasn't early, it wasn't negative, it wasn't trials showing harm. It was all physiologic reasoning. Okay, you have worked very hard. You deserve a break for lunch.